Hi everyone, my name is Megan Brotherton from the Australian Safe Communities Foundation, and along with Tanya Peters from Safe Communities Foundation New Zealand, we're your hosts for this webinar. Before we start, just a few housekeeping matters. We have three fantastic presenters today who will each have 15 minutes for their presentations, and if time permits we'll have a couple of questions after each presentation. Each participant has access to the GoToWebinar control panel on your screen, and please familiarise yourself with its features. If you're having any problems, please send a message to the organisers via the control panel and we'll endeavour to resolve the issue. If you'd like to ask a question during the presentations, please type your question into the question area on the control panel on your screen, or you might wish to put your hand up, which is the little hand, yellow hand on the control panel, and at the end of each presentation, depending on the time, the presenters will try and answer a question. If your question isn't answered, the presenters will provide an email address at the end of their session for you to correspond to them personally. The webinar will be recorded and available for viewing early next week. So now I'd like to start the falls prevention webinar and would like to introduce our first presenter, Glenys Bell.
Hi everyone.
Muted.
My name's Glenys. I work for Nelson-based Primary Health. I'm hoping you can all see and hear what's going on. I'm part of the Safe at the Top. One of my roles is Safe at the Top coordinator. Safe at the Top is our region's Safer Communities project. You'll see the red circle down here as to where in New Zealand we focus, where we're based in the Nelson Bays area, which is down here and across to Golden Bay. So they call it the Top of the South. Focus of the project that I'm working on is the home safety, of which falls prevention falls under that task group. And the focus for the age group is over 65-year-olds. Just a little bit of background. The false claims, ACC false claims for over 65, false claims, you can see here, majority of the false claims from ACC, which is where a lot of our false claims go through for payment, and it's like an insurance payout. Most of those claims come from within the community. You'll see hospital and residential care, some of those claims, but community, definitely most of the falls are happening within the community. These are the falls for the over 65-year-olds during a 1-year period. You'll also see, when you look at the big picture, all claims from ACC, you'll see here that falls are a very significant part of the expenditure or the costs occurred by ACC. So that's why ACC take a very strong interest in falls and why they keep funding our particular program. So what did we do? This wee short presentation I've got is based around accounts-based, results-based accountability feedback. So it's a little brief snapshot about what we're doing, how much we've done and what outcomes we've had. So under the what did we do for our region, we actually established what we called a falls alliance. So that was the hospital and the primary health organisations, the organisations that work within the community. So we all got around the table and got together and all started heading in the same direction, which was quite unique. Apparently it hadn't happened anywhere in New Zealand before. Out of that alliance we developed 3 work streams. So those work streams were based around community and primary, secondary, what happened in the hospital, that was inpatients and outpatients, and then AIDS residential care. So there was focus in those 3 areas and a whole lot of activity that came out of those particular 3 areas, but they were all linked. And that was the unique part, was that we were all saying the same thing, we all had the same resources, we were all together working in the same direction. And eventually over time, after a couple of years, after about 3 years, we've developed what we call a single point of entry. So all falls referrals came to this one single point. I'll talk a little bit more about that. So our model, if you had a little snapshot of what the model is that we do for falls prevention, we do the asking, so actually asking people have they had a fall in the past 12 months. So we try to identify the fall, we then do a very brief assessment on perhaps what's causing the fall or what's needed, and then we do some actions. And so it's no good doing the assessment unless you do an action that follows that. So the action has what we've developed as that single point. So all referrals come to that single point, and then from that single point we can determine what's the most priority for that person and what is it they want or need, and try to send them in the right direction. You've got a couple of options there. Then of course once they've had some educational information, it doesn't stop there, it carries on. So we refer them on to what's happening in the community. So these are existing community groups. We feed into them because we know that keeping the person active with strength and balance is what's going to maintain those falls initiatives. And we follow people up for 6 months to see how successful we've been. And you might not be able to see that the little building block on the side was actually, we started building this from the bottom up. So we built this bottom part. It took us 3 years to build that because it was no good having all these referrals if there was nowhere to send them. So we built down, so we built from the bottom up, making sure we had a good strong foundation to build onto. And if I just show you this, I know it's very, very busy and confusing, but just very briefly, these are all of the people who are potential referrers into this single point. So we're looking at hospitals, inpatients, outpatients, community services. We're looking at general practitioners, we've got doctors, we're looking at St John's, the ambulance, and we're looking at health professionals like the private providers, the physios, podiatrists, optometrists, all sorts of things. So there's an awful lot of referrers that are now coming into this single point, and we now have a triage process just to try and manage all these referrals. But there's also options for them. Not everybody wants to go into this upright and able, which I'm going to talk a little bit more about. So we have lots of referral options to send them onto, and they all feed into these community programs because we want that sustainability. So what we did in that primary and the community work stream, it's like we spent the last 3 years developing what's called upright and able. So that's our falls prevention education program. So it incorporates education and physical activity. So we target those that have had a fall. We have quite a large reach. We are able to manage quite a big capacity, a lot more than what ACC has ever been able to manage previously. We combine the group education and exercise, and it's in a self-management model because we want to empower the people that are there so that they can sustain that knowledge and then act on that knowledge. It's adaptable, so whatever place we go to, we can adapt it to suit that region, and it's sustainable because we're building on existing services and we incorporate what's happening in the community. So we're feeding into them, which keeps them sustainable, and so on it goes. So it's quite an empowering model all around, really. How much did we do? So if we look at a 12-month period from in 2013, we delivered 26 upright and able courses. So that's a multiple course. This particular time it was 3 weeks. People attended once a week for 3 weeks, and we delivered that right around our whole region. So we delivered 26 of those 3-week courses, and we had a total of 371 people attending. We also did staff training or volunteer training, because the more people that could identify and assess, the better there was. So it's an empowerment model, remember. So we did 25 staff training, and 580 staff from various organisations attended that training. In total, participating in the community programs, so that's the programs they go into once they finish this 3-week education program, there was 2,235 people participating ongoing regularly every week in a community program, all doing some options at home. So that's quite a significant number of our older adult population. So how well did we do? If we look at the ACC data for fracture rates, you can see that for our 85-year-olds, or those 85 and over, there was quite a peak. Now this was related to the Christchurch earthquake, if anyone's familiar with the Christchurch earthquake. A lot of retirement villages, all the retirement villages were evacuated to Nelson, so we had the peak is related to all those evacuees coming to Nelson. So there are a lot of hip fractures as a result of all of that trauma. But you can see how that's now dropping dramatically. So hip fracture rates in our region for the 85 overs dropping dramatically. Another drop in the 75 to 79-year-olds, slight increase in the slightly younger people. But of course, this hip fractures, these are the most significant ones, so lots of reductions there. If we look at the age of people that attend upright and able, you can see that age group where we're having the significant drop in hip fractures is our significant age group that attends the upright and able course. So we are capturing the older age range, and these younger ones, we're not getting very many of those. So perhaps that's something we certainly need to be looking at. But age range, quite interesting. This was some research that was done from a research company called UMR Research Associates based in Wellington. We had researchers come over from Wellington to do this. And they looked at our falls rate. So they looked at the number of people that had had a fall prior to attending. And then they looked at the number of those people who had fallen after they had attended that 3-week program. And there was a significant reduction in falls, because we know if someone's had one fall, they're more likely to have another. What we did learn from this, though, that was we suspect the falls rate is higher than the 51 or 52% that's showing here, and that was an interpretation thing. A lot of people had different beliefs about what they classify as a fall, so we certainly changed our terminology from this research. So that was one of the learnings we got out of that, because we believe the falls rate was higher, but still showing a significant drop. When we first started doing it, falls prevention initiatives in our region were reaching 4% of the population. After the first 2 years, we were on 12%, which is what that yellow dot showed. This yellow graph shows, and this is where our target is. ACC have set a target for us to reach 20%. We are currently on 15% now, so we're almost there, and we've got another 2 years to go to reach that. So significantly, statistically significant, we're reaching 15% of our older adult population in a falls initiative, which is pretty cool. The greatest outcome, I believe, is that 89% of those that attend the 3-week Upright and Able program are still participating in falls initiatives, doing the community program 6 months after they've completed the education program. So, so long-term sustainability, that's huge. People don't just learn something and then stop, they learn something and then put it into action, which is pretty amazing. Is anyone better off? We did focus groups as part of that research. Here's our researcher, very young. We had to teach her how to speak because she spoke far too fast and quickly. But from the older adults that were involved in this focus groups, we heard some amazing stories, and it's from those focus groups we learnt that, okay, the terminology we use about asking someone if they've fallen was perhaps not right, so that's what we changed. But yes, some pretty amazing outcomes, more than just preventing falls, you know, reducing knee replacements, changing someone's life because they now no longer need their walking frame, person able to actually wear shoes instead of slippers. So quite significant outcomes. Learnings, we certainly learned a lot along the way, and we continue to learn. Even though we're 4 years down the track, we are still learning. Every year we learn more. What we learned about Upright and Able was that we need to keep it simple. And I think to start with, we were putting too much information into the education. So we culled it right down. Less is best was our motto, and people seem to remember more when you give them less. So yeah, we've certainly simplified it. Relationships and partnerships, linking into what's already existing. Like St John's, they pick up quite a lot of people that have had a fall in the home, but they're not injured enough to transport them to hospital. So we linked in with St John's, and those referrals now come through the single point of entry, because that's the perfect stage to be putting an intervention in before they need the transport to hospital because the injury is so severe. So really the prevention part is quite strong there. Develop the pathways, that's having all of the referral options, because not everyone fits in the same box. We need to have lots of options. And it is based really around the person's priority, not our priority, because the person needs to take responsibility, and to do that they really need to believe that that's what they need. Support community exercise providers, so the community groups that form the bottom layer of our sort of pyramid, I guess you could say, they're the key to us, because if we don't support them, then they're not going to incorporate strength and balance exercise, they're not going to be trained and skilled and knowledgeable, and we're not going to have the confidence that people will be safe in those programs. So we support those exercise providers, certainly build on what they already know. We keep sending them referrals, so they keep getting lots of people paying their small $2, $3 each time they go. So that is like a sustainable model. There's lots of sustainability there to keep on going. At a strategic level, we did need that alliance group who was able to influence higher up. They were what we call the unblockers. But to have the whole region connected was certainly a lesson worth learning. The pathways and again the partnerships there, and consistency, the same message, the same resources, people get reinforced everywhere they go with the same things. So if you want to know more, email address there, website's got some information, and happy to provide further detailed information for anyone that wants it. Thank you.
Unmuted.
Thank you, Glenys. Did anyone have one quick question that they wanted to ask or put their hand up for that we can get Glenys to answer online? I don't see any hands up at the moment. If not, we will move on to our next presenter. I'm just checking there's no other questions. So now I'd like to introduce our next presenter, which is Emily Anderson from the Injury Control Council in Western Australia. Thanks, Emily.
Muted.
I'm from, one second, this screen. I'm from the Stay on Your Feet program, and I'm talking about our messages and our 9 steps to stay on your feet. I'm from the Injury Control Council of WA, and we're the not-for-profit organisation involved in injury prevention and community safety in WA. Our mission is to reduce the incidence of injuries and their effects, encourage, promote and engage in research into injuries. We have many program areas, including alcohol, community safety, suicide prevention, but today I'm obviously going to be talking about falls. So what do we know? We know that falls are a significant health issue for Australian adults aged 60 and over. Falls prevention has become an increasingly important public health intervention in the context of Australia's ageing population. We know we have limited guidelines that exist for the transition of knowledge of falls prevention between health professionals within clinical settings. We know that population-based falls prevention programs are cost effective, and we know that a gap exists for comprehensive coordinated population-based falls prevention programs. Population trends estimate that by 2031, 20% of Australians will be aged 60 and over, increasing the need for effective initiatives to prevent falls. The literature surrounding the community-based falls prevention programs suggests that programs vary greatly in the significance of the results. Clinical studies have identified risk factors and subpopulations as the most important elements when considering the cost effectiveness of programs. Strength and balance exercise programs, in particular Tai Chi, have repeatedly proven to be the most effective strategies when integrated into community-based programs. Compared with clinical interventions designed to inform the management of individuals or small groups, there's limited research into comprehensive strategies to reduce related injuries within the population. So what is Stay on Your Feet? We're funded by the Department of Health Western Australia, and we aim to improve the knowledge, attitudes and beliefs among seniors that falls are preventable, reduce the incidence of falls and reduce the severity of falls-related injuries. And we do this through a number of different ways, including professional development for various industry professionals, resource development, so flyers and pamphlets, expos and displays, presentations including using volunteer peer presenters, newsletters and awareness-raising campaigns. Our main tool for both messaging tool for both health professionals and the general public is our 9 steps to stay on your feet, which you can see on your screen. They're all evidence-based messages, and as you can see, they're pretty simple, and there's 9 of them, obviously. So in 2012, Stay on Your Feet reviewed all our existing strategies, resources and initiatives to determine their impact in terms of branding, awareness and understanding, attitudes, beliefs and behaviour change, and preference and perceived value. We engaged this WA Centre for Health Promotion Research, or WACHPA, they're based at Curtin University in WA, to undertake the evaluation. We also work with WACHPA to upskill our staff in terms of learning more about evaluation. So we had various data collection methods. We had a rapid desktop review was conducted, a CATI survey, so a computer-assisted telephone interviews. We had 500 interviews conducted, which is great. We had an online survey for health professionals and telephone interviews with health professionals, but what I'm going to focus on is our focus groups that we conducted with community members and health professionals in this talk today. So who did we talk to? We talked to, we had 8 focus groups, 4 with community members and 4 with health professionals. And the community members were recruited from our Injury Control Council database and other databases such as Council on the Ageing and Seniors WA. And our health professionals were recruited by various methods, but we ended up with professionals that were gerontologists, physiotherapists, fall specialists, and many more, as you can see there. Just a bit more about who we talked to. In the community demographics, a large percentage were female, and as you can see, we had quite a significant number of people who did not have a fall in the last 12 months, so it suggests potentially we talked to rather a well population. We also talked to mainly female health professionals, maybe suggests the representatives of the industry, or maybe representative of the industry. We also had a large number of physiotherapists that we talked to, which may also be to do with the fact that they identify as being related to falls. So what did we talk about? We had questions were designed to have discussions among the participants, but they all were focused on the 9 steps. Questions included the following, including what actions would be suggested to prevent a fall, what were the 3 steps that are the most important of the 9, and things such as could the steps be combined or removed. So what did we find out? This is a word cloud that was put together. The word cloud is of the community members' association with the word falls. community members were asked for some of the words that come to their mind when they heard the word falls, and discussed their attitudes and perceptions about falls. So obviously you can see that many of the responses centred around the causes of falls, such as ladders and pavements, and the consequences, including broken bones and embarrassment and pain. The words in the larger fonts were mentioned more commonly. So is 9 steps too many? Many participants agreed that 9 steps were too many to remember. So, things were said such as 3 is a good number, it's enough information for people to remember as opposed to 9. And I think there's a risk when you have as many as 9 messages that you lose the message partway through. So the question was then, how many is good enough, or how many is a good number? Many said that 3 is a good number. It's enough for it to remember. So what about combining steps? Some groups suggested that combining steps under a new heading, while others suggested keeping all the steps or grouping them. So as you can see the quote there. And what about linking steps? Could that equal a loss of information transfer? So it was discussed potentially if we group them into 3 lots of 3 steps, could the messages get too lost within the messages? 2 out of the 4 health professional groups, focus groups, did not develop a new list of steps, as they were in favour of keeping the original 9. Health professionals also frequently reported that the importance of particular steps often change depending on the age or current health status of the individual that you're dealing with. So this moves us on to the importance of the delivery. This came up quite often, as mentioned before. So different steps for different clients. So knowing who you're dealing with is important, and being able to pick out which of the 9 steps is more important to your particular client. So this brings up, do we need resources tailored for specific groups, or should we provide training to health professionals on how to deliver generic messages but tailored to the specific individual? So does the message work? So be active, improve your balance were consistently voted as the most important steps. All of the 9 steps were considered important for falls prevention. The 9 steps were considered a useful tool for falls risk assessment and personal action plans, and how the 9 steps to stay on your feet are used should be strongly considered. So recall of the 9 steps. Some of the health professionals suggested condensing the 9 steps to stay on your feet. However, this was countered by other health professionals claiming that key messages would get lost. Other health professionals proposed a tailored use of the 9 steps to stay on your feet in a clinical-based setting on the community member's age and physical condition. The latter was forwarded as the more appropriate option, as age brackets are not always representative of the person's mobility and health needs. Volunteer presenters, so our peer presenters who present to the community, also suggested that tailoring a presentation of the 9 steps to stay on your feet based on the health needs of an audience would be appropriate. However, this may prove problematic at community events with a range of attendance. So last year we had a second phase of our evaluation. We focused on our awareness raising initiatives, which were Stay on Your Feet Week, which is usually held in September, and within that week we also we have organisations that host events focusing on the 9 steps to stay on your feet. They may have presenters or host a morning tea. We also have, give out grants for organisations to host these events, and we also host April No Falls, which is a month-long event aimed aimed at upskilling health professionals in hospitals, aged care and home and community care settings. So we were evaluating the preferences and perceived value, the program reach, the motivation to change and behaviour change of these programs. So the methods that we used for this were interviews with event coordinators and event participants, and we also had online surveys and a short literature review. Once again, we engaged WA Centre for Health Promotion and Research to help us with this evaluation. So the findings from this was that the programs were well received by event coordinators and participants. The events were considered valuable, and it was suggested that they continue or be expanded as part of the overall program. The assistance by ICWA staff was reported to be positive by participants and coordinators, and there was discussion around the capacity of the evaluation regarding its focus on process measures rather than long-term outcomes. Event coordinators tended to conduct process evaluation. However, outcome evaluation was not systematically conducted, providing limited evidence for long-term change. Much evidence regarding motivation for change directly following event was captured, although capacity for event coordinators and Stay on Your Feet to follow up longer term regarding behaviour change was limited. This was some of the reasons that participants ended up attending the event. So they were interested and wanted to learn more about Stay on Your Feet, or the 9 steps to stay on your feet. So once again, some of the bigger words were the words that came out in the evaluation. As you can see, there wasn't much about behaviour changes, such as a reason to attend an event in the first place. So key recommendations from the evaluation about these awareness raising initiatives. The grant process, it was suggested that we give out fewer grants that were for longer projects rather than for one during the week. And to provide significant support for event coordinators to ensure that they're providing the best possible events for their participants. And the evaluation suggested that the agencies that were getting the grant funding, as they were asked to evaluate their programs, then it once again needed to be supported in this and given the opportunity to potentially get longer-term evaluation data and focusing on long-term behaviour change rather than just motivation to change post-event. Sharing information, so using the people that are involved in the events and sharing what they learn from the events, that's a key recommendation. And the resources as well. Message branding once again came up in this, which had very similar results to what we were discussing in the previous evaluation. So limited recall on all of the 9 steps to Stay on Your Feet, and suggestion to use the 9 steps as a tool rather than a main message, rather than to be promoted. Health professionals could be guided to choose relevant messages. So where to from here? We're moving forward to using the 9 steps to Stay on Your Feet as a falls prevention tool rather than a falls prevention message. So rather than sharing it out to all the messages and saying, here, learn all these, let's use it as a tool and focus on a few of the steps or one of the steps depending on the person. Develop a more succinct message for falls prevention. I think that's an issue across the industry, so we're definitely going to be working on that over the next little while. And provide practical guidelines on how to use the 9 steps including health and wellbeing services. We are very happy to announce that we've been funded for the next 3 years and potentially 5. So this gives us a great opportunity to use these recommendations and promote them to the community and adapt our program to reflect the recommendations. As part of our funding, the next 6 months is a key stakeholder and community engagement time, which is exciting for the program and falls prevention generally. And we will be focusing on targeted interventions, as this came across as a key recommendation across both evaluations. Thank you very much. That's our general
Unmuted.
email. If you email that and ask Emily Anderson, I'm happy to get in contact with you if you have any questions. Thanks.
Thank you, Emily. I did see that there was one hand up earlier, so I might ask that May contacts you directly given our timing. So I'm now like to hand over to our final presenter for today, who is Annette Biviano.
Can you hear me now?
Yes, we can.
Yes, you can. Marvellous. Thanks.
Muted.
Okay, so thank you very much, Megan, and to the Pan Pacific Safe Communities Network for asking me to speak today. My name's Annette Biviano. I'm a falls prevention physiotherapist at Knox Social and Community Health, and I was also the project officer for the Outer East Falls Initiative from May 2011 until the project was completed towards the end of last year. So this is the project I'll be presenting about today. Just to give a session overview, it'll be a very brief overview, and at the end of the, well, it won't be that brief. I'll be including a lot of information in the overview, which I'll skim over a bit. And at the end of the presentation, I've put my contact details. So if you'd like further information, please contact me. So we'll be covering the background and framework for the project, planning for sustainability and risk management that we did, how we established the project and the groups, a couple of case studies from the groups and project completion, group sustainability, and some key recommendations. I won't be covering the data and statistical findings. They're currently being analysed by Professor Leslie Day from the Monash University Accident Research Centre, and she will present on those at a later date. So the Outer East Falls Initiative commenced in May 2011 and completed towards the end of last year. It had good foundations because it started with a partnership and collaboration between the Victorian Department of Health, Aged Care Branch, and the National Health and Medical Research Council. So all good health promotion starts with the policymakers and the funding bodies. And they were asking the question of which single falls prevention intervention is most effective for preventing falls amongst community dwelling older people in Victoria. 6 projects were funded around Melbourne to look into this. So in the eastern region, falls prevention exercise groups were funded, and we were one of the 2 projects funded in the eastern region, and they were being compared in other regions with individual home exercises, which were done by physios with older adults in their home, and with home modifications done by OTs, but not directly compared, but just all were being looked at to see that they were effective. And we were given guidelines on what type of exercise that would be acceptable for group exercise based on the literature available at the time, and we're also given sustainability guidelines to follow because sustainability was on the board right from the start. The key partnership organisations for our project, which was the Outer East Falls Initiative, were 2 community health centres, and that's Knox Social and Community Health and Inspiro Community Health. We had the Outer East Health and Community Support Alliance, and the Chinese Community Social Services Centre were also key partners. Our objectives were to establish a minimum of 3 sustainable falls prevention exercise groups for residents aged 70 and over in the Outer East metropolitan region of Melbourne, which is a very large area, in fact, to establish these groups in. We wanted to provide a 15-week program, exercise program, and we decided to choose the No Falls program and the Tai Chi for Arthritis program as our exercise options, and we wanted to reach 270 exercise group participants. We wanted also to be training leaders in falls prevention exercise, so group leaders, and we wanted to reach 60 staff and volunteers across the region, and we wanted to build new interagency partnerships and strengthen existing partnerships. So we had a lot of things on our agenda. We started off with risk management. In the establishment phase, which went for about 3.5 months, we just only had the project officer on board, which is myself, and we had NOC social and community health staff such as the manager and team coordinator, Anne Elkins and Edna Wong. They're very well networked and very experienced in setting up partnerships, so they set up the project very well at the start with the right from the funding submission. And then if we look a bit further onto what we looked at next, we did a literature review, and also from my experience as a falls prevention physiotherapist, I've been running similar programs for many years, so looking at our experiences, we wanted to, we knew it was essential to ensure adequate staffing of the exercise groups because we're working with higher risk clientele, and we don't want falls happening during the exercise groups because that's not good for anybody. So we needed to work out a way we were going to get enough staffing because we only had, in fact, less than one EFT of project staff. So where were we going to get all this supervision to enable safe and effective balance retraining, individualised exercise progressions, challenge to balance at a moderate to high level without participants falling, and how could we ensure consistency, safety and effectiveness of the exercise groups? So we wanted to use evidence-based falls prevention exercise programs, and preferably ones that had established training packages. And based on that, we offered our group partners the choice of 2 researched and effective falls prevention exercise programs. The first one was the No Falls exercise program, which includes strength training, postural stretches, vestibular exercises and balance exercises. And also we offered the Tai Chi for Arthritis program. In terms of risk management, we looked at other areas of risk management as well, such as sustainability. What if we didn't get, first point, enough participants recruited, or couldn't get enough groups established, or no one wanted to be our partner organisation? What if we started up these wonderful groups and then they fall into nothing at the end and it's all a waste of energy and time? And sustainability had been on the agenda right from the very start when the funding submissions were asked for. So I've already mentioned our key partner organisations, and they became our steering committee, but we also invited onto the steering committee the Greater Eastern Primary Health, which was the key body in our area at the time for linking with GPs. So they had an email network to the GPs and organised meetings, and they were a really good avenue for us to be getting the message out there to the GPs. As well as our key partner organisations that I've already mentioned, we had a number of group partner organisations. So we set up the model that we set up for how we were going to get around this staffing problem and getting enough helpers on board and enough experienced and quality staff to lead the exercise groups. Was we decided we'd use a community development approach, and we'd look for agencies and organisations across the Outer East who'd like to partner with us in running the exercise groups. And that worked really well. We ended up with 10 partner organisations, but there were actually 14 groups because some of the partner organisations did more than one group. And in fact, towards the end of the project, we were actually having to say, sorry, we're at capacity, because there were other groups contacting us wanting to be part of it too. The ones in blue are the community health services in the Outer East. There was one other community health service, unfortunately, who wasn't able to participate, but we had pretty much most of the Outer East covered for community health, and each of those community health centres chose to do the Tai Chi program. In addition to that, one community health centre also did the No Falls program. All the other group agencies chose the No Falls program, some of them because they were already running a Tai Chi program. So the ones in green are the University of the Third Age. We had 2 groups, and then in the indigo purple colour we've got the 3 planned activity groups. 2 of those were specifically for the Chinese community, and in grey we've got a gym program for older adults, the Spartans Gym, and they were our gym program. We also planned towards sustainability through education and training, and we knew that if we wanted to have sustainable groups and we wanted to ensure safety and effectiveness of the groups and consistency and quality control of the leadership of the groups, we were going to really need to be able to train up lots of new leaders. So we actually started off by organising a master trainer to come from interstate to train some falls prevention health professionals in Victoria to be no falls trainers. And that meant we then had the skill base that we could then offer that those no falls leader training workshops without any charge to our OFI groups, our Outer East Falls Initiative groups. So we had 5 of those no falls leader training workshops. 2 of them were actually Chinese-speaking ones. I don't speak Chinese. Fortunately for me, my direct line supervisor, Edmund Wong, does speak Cantonese, so he interpreted. So that was really lucky because some of the staff and volunteers from the Chinese community groups did not speak English. So that was a really convenient opportunity, and it just showed the flexibility too, how on board the staff at each of the community health centres and each of the agencies were, that there was that flexibility for someone who is in a management role but has a background in physio. He was happy to step into that role for this project. So that was fantastic. And there was a lot of in-kind funding by the community health centres, I suppose, too, in making their staff available for these things and not expecting it all to be happening through the project staffing. And we also offered an accredited Tai Chi leader training so that the groups who were running the no falls, groups who were running the Tai Chi for Arthritis program, we could get leaders trained from within them. So for example, we had an Aboriginal Tai Chi group and we had one of the Aboriginal participants who actually trained as a leader to help for sustainability. Staffing, I already mentioned, we had less than 1 EFT. So we were really fortunate that we used that community development approach and worked in partnership with community agencies because a lot of our staffing for this project came from the agencies we partnered with. We deliberately split the physiotherapy hours across the 2 community health centres who were involved with this project. And we did that to ensure that we had a bigger reach in terms of the networks, to build collaboration across the community health centres between the physio staff, and to help sustainability of the groups at the end. So that really paid off for us. And we were very fortunate that our allied health assistant also was a master Tai Chi trainer. So that was really good because between the physios and the AHA, we had both types of groups. We had experts in both types of groups. But just to show you, this comes from the survey that we did at the end of the project, the feedback survey, and you can see the dark orange actually shows that almost half of the staffing were volunteers. Now, we didn't recruit those volunteers. Each of our partner agencies recruited their own volunteers, and somewhere like the U3As are a wonderful agency to work with, a wonderful organisation, because they're all retired people and they're used to a whole the way they operate is everybody there is a volunteer and takes on leadership. So a lot of self-responsibility and willingness to step up, and of course an amazing amount of skill base because these people were, you know, nurses or whatever in their working life and can bring all those skills in. Participant recruitment took care of itself. Once we got the ball rolling, it took care of itself. So initially it was things like articles in the local newspaper, lots of, I put together templates for the physios who were doing the assessments so that we could have letters going out to the GPs very easily, and also on reassessment of the participants there was one that showed their progress, lots of brochures and advertising material. So once the groups were underway, or once we got a bit of a roll on, in fact each of the group partners was so engaged with their group and the ownership of their group that they were marketing it. They'd have their own newsletters, they'd have their own links at the local paper and at the local council, and that they'd be marketing it themselves. So there's some of the literature. We also started off at the on April Fool's Day in 2012 with project launches, and we had 2 of them, one in at Knox Social and Community Health and one at the Yarra Rangers U3A, which they hosted themselves and took responsibility for, which was great. So the looking at the community development approach. Of course, we did have a little bit of a constraint because we did have guidelines that we needed to fit within. We were looking at falls prevention exercise and it needed to be effective falls prevention. So someone did ask us for hydrotherapy groups, and that wasn't within our within our parameters to offer that. In establishing the 14 groups, each group had a group development phase, and just as an example, the Aboriginal Tai Chi group, right at the very start of the project, I started on the groundwork for that, and I was meeting with the Aboriginal liaison officers and Aboriginal health workers from across the region. We had a number of meetings, and between meetings the workers would go back to their communities, to their managers, and work out what they could offer. Were they happy to be a group partner? Were they happy to refer into the group? What were the needs of that community? We then were able to organise where they'd like the group located, sorted out a venue, transport to the group, and in fact the Indigenous Health Service even provided lunch for the group each week, so they were our most well looked after group. We did have specific ethical issues because of it being an Indigenous group, so the research assistant from Monash University Accident Research Centre came out with us to Hillsville to discuss those and make sure that the ethics requirements were all going to be met, and we did recruiting and advertising, etc. We also did a training program so that some of the staff from the agencies in that area, including the Indigenous Health Service, and a member from the group, from the Aboriginal community, were trained as Tai Chi leaders. Just as an example of a different group, the Chinese Community Social Services Centre. This is a training day for the staff and volunteers from their centre, and as I say, Edmund was great in translating for me. Following the training, within a week we'd always organise an assessment morning or assessment day for that group that we were about to start with, and they'd all have an individual physio assessment. So often this was physios, even across agencies, cooperating with that. So I might have helped, for example, at Spartan's Gym with the Inspiro Physio, and we did the assessments together. So this was a great opportunity for that interagency sharing of ideas and cooperation and collaboration, which is great. There was a 15-week program for everybody, whether they did Tai Chi or no falls, and they'd have some refreshments and a home exercise program. There was quite a well-documented home exercise program with diagrams. And then at the end of their program, each participant was reassessed once again by the physios and was given a letter for themselves and the doctor which showed their progress. And each group had a particular logo. That's one for the Chinese group, and this is their group in action. So this particular group had up to 28 participants, and an interesting thing is with the planned activity group, we couldn't select out the people that we didn't want in there because their arthritis was too bad or whatever. So we had to work out ways to get around that problem. On the left, there's a circle of half the group doing their strength training, and on the right, people are actually going individually to do their balance exercises or the balance recovery, and they'd start with using a ledge for a rail and then move over to a wall where there's less support, for example. And I'm not going to talk much about this. This is the Knox U3A group, other than to say it's such a lovely community. It's like a small country town. The main issue I've had really with the group leaders is emphasising confidentiality when they go to their other U3A groups, that they're not there in a leader capacity, and they need to respect the privacy of the people they're working with. So that's of interest. And just to see how skilled the No Falls leaders have become who've trained through that U3A. So with the completion phase, we had Department of Health, we had Professor Leslie Day from UARC, and we had everyone from volunteers through to staff who'd been involved there, and we had a big celebration. So just to highlight a couple of issues, we had issues to do with equipment, but that was a great opportunity to link with another agency anyhow, because one of our local men's sheds ended up making the equipment for us. And one other thing probably to highlight out of this page is the recruitment of participants aged 70 and over to the Tai Chi groups was very poor, and retention of the Tai Chi participants wasn't good. So the No Falls program actually came back also on a feedback survey as being more preferred by the group partners and the people we trained. We had many successes, and I love the interagency collaboration between the physios, lots of sharing of resources, working together, upskilling of each other, so that was a real highlight for me. New and ongoing partnerships formed with the U3As, and we've got further collaboration planned. All the groups have been sustainable. They've all continued, the 14 of them. The only thing is the Tai Chi for Aboriginal group actually had to merge with another group. The others all continued. All our partnerships have strengthened, and we've got better referral networks to, like the Falls and Balance Clinic at the local hospital and local private, everyone from osteopaths through to orthotists are referring through to us now. So the outcomes of the project were far greater than the cost of the one EFT of staffing, and there are 93 newly trained and now experienced falls prevention exercise leaders, which is great, and high satisfaction levels on the feedback survey. We exceeded all of our targets, which is marvellous, and we are in ongoing partnership with the U3As, and we have a plan for regular once-a-year upskilling for the leaders from those groups, so that we can train new leaders to keep the sustainability going, keep feeding into it, and keep their qualifications and knowledge up to date and current. So I highly recommend using a community development approach, the use of leverage through the use of volunteers and partnerships, education and training to promote a skilled, safe and effective exercise group leadership, collaboration between agencies to achieve shared goals, the value of expert, flexible and committed project staff, use of evidence-based falls prevention exercise programs which have a training module if possible, working towards sustainability from the first conversation, build on the networks of a committed steering committee, ours was fabulous, and partnering with established groups like the U3As and the gym groups really saved time. These were just some references for people who aren't familiar with falls prevention, and that's the end of my presentation. Thank you.
Unmuted.
Thanks, Annette. I also wanted to thank all of our presenters for today, and given our time, we will ask that you feel free to email any of the presenters or the organisers with any follow-up questions that you might have. Our next webinar will be on workplace safety on the 31st of July, and further details will be circulated closer to that event. Thank you everyone for being part of our webinar today. Enjoy the rest of your day.